Hello, very good afternoon. I welcome you today to another FB live session. I, Dr. Nilesh Balkawade, Clinical Head at Oasis Fertility, Pune. I welcome you to another clinical session of FB Live on thin endometrium. Many of the times we hear doctors performing IUI or those patients who are going for IVF cycle. The doctors do say that you have a thin endometrium which is not responding in spite good treatments. So basically, what this thin endometrium means. Sometimes it can be called as a thin endometrium, or the lining is poor, or the ET is not good. All are one and the same. The ET is the endometrial thickness. And today we are just going to get a perspective of what is thin endometrium. For a woman, the most magical day of her life is when she becomes a mother. And in the journey to motherhood, there can be problems at times. Infertility is one of such problems. 1 year of her trial, she is not able to conceive. In those patients, we say that this is a case of infertility. Infertility can have various causes, like the ovarian cause, the male factor, the uterine cause, the tubal cause, and so on. In the uterine factor, we can have something called as thin endometrium, or the innermost aspect of the uterus, which is at problem. So basically, why there is a problem because of the thin endometrium? For this, we'll just go through this soil and seed theory. So, for a fresh sapling to grow, one should have a good seed. But along with the good seed, a good soil is also necessary, and sometimes good oxygen supply and sunlight too. Basically, the soil and the seed both should be good so that the sapling grows well. If there is a problem in the seed, then the sapling won't grow. Or if there is a problem in the soil, then also the sapling won't grow. Today, we are going to talk about the soil, which is the thin endometrium. So, the pregnancy, where it attaches, receives its blood supply and nourishment, is the endometrium. And if that endometrium is at a problem, then the baby or the fetus won't grow inside the womb. Basically, if we see for the anatomy, the uterus is composed of the outermost layer called as serosa, the middle portion or the myometrium, and the innermost portion or the endometrium. The innermost portion or the endometrium has to grow to a sufficient size for implantation to occur. And this size, by many of the studies, has shown to be more than 7 to 8 millimeters in thickness. Is only the thickness important? No, there are other factors too which we will consider. Yes, but this thickness is one of the important factors of endometrium so that it becomes receptive for the embryo to implant. When will be there a problem in the endometrium? Is when the endometrium is too thin to allow the embryo to implant. And now, what are the causes of this thin endometrium? Thin endometrium can be the most common cause being infections in India. Infections can be either ascending infections in the form of sexually transmitted infections like chlamydia, gonorrhea, and so on. Other infections in the form of tuberculosis, which primarily affect the endometrium and the fallopian tubes. If the endometrium is affected by tuberculosis, it won't reverse unless and until you receive the anti-tubercular treatment. Other forms of modalities of treatment can also be used. Other causes of thin endometrium are iatrogenic causes where the woman has undergone a DNC procedure, which is a dilatation and curettage of the endometrium. The DNC procedure, if done in a very harsh way, and if the basal layer of the endometrium gets damaged, then the endometrium tends to develop adhesions in between itself, and the growth of the endometrium is hampered in subsequent part of the life. Especially is so when a post-aborted or a post-delivery dilatation and curettage is done. The endometrium has higher degree of damage in such scenarios. Other surgeries which can damage the endometrium are aggressive myomectomy, uh, especially a hysteroscopic myomectomy where the part of endometrium damage was more. Sometimes a laparoscopic myomectomy where the endometrium was entered, or in cases where Strassmann surgery was done for unification of two separate uteri. In those cases also the endometrium can get damaged. Other patient having gone under treatment with radiotherapy or chemotherapy, the endometrium can be damaged. Prolonged oral contraceptive pill use can also make the endometrium quite thin. However, it is most of the times reversible. Ovulation induction agent used called as clomiphene citrate can also thin out the endometrium. Some congenital Mullerian anomalies can manifest as thin endometrium. These are unification abnormalities or septic uteri, which can make the endometrium relatively thin. And in some cases, it will be idiopathic causes. How do we diagnose thin endometrium? Endometrium is thin or not is usually diagnosed in a secretory phase or the luteal phase of a menstrual cycle, which is usually after the 14th day, that is the ovulatory period. The period where you judge the endometrium whether it is thick or thin usually is around 18 to 22nd day of the menstrual cycle, where the endometrium has to be in a maximal thickness with maximal blood flow, and that is the window of implantation in natural conception, which is usually around 21st or 22nd day of cycle. So during this period, the endometrium usually is around 8 to 12 millimeters in thickness. If the endometrium is less than 7 millimeters in thickness, we call it as thin endometrium because this has shown to give poor pregnancy results in both natural conception, in IUI cycles, and also in ART or IVF cycles. We have to see the cause for this thin endometrium, and this can be judged based on the pattern of endometrium which is there, the blood flow of the endometrium, whether there is any fluid collection within the endometrium. If there is a fluid collection in the endometrium, you can suspect any infection in the tubes like hydrosulfings, which is mostly caused of tuberculosis or other sexually transmitted infections causing PID, and this can affect the endometrium as well. Sometimes excessive dose of estrogen can also cause fluid inside the endometrial cavity. We have to find the cause and treat, obviously. What are other methods or modalities of diagnosing a thin endometrium? A three-dimensional ultrasonographic picture can tell us whether the endometrial volume, the endometrial pattern and spread are good or not. It can also tell us the causes of thin endometrium, such as adhesions formed post DNC or due to infections. This can be very well detected on a three-dimensional ultrasonography. Mullerian abnormalities like septic uteri can also be detected on three-dimensional ultrasonography. We talked about whether only the thin endometrium is important or some other factors are important. So whenever the endometrium is thin and it's not improving, we have to take into consideration other factors such as the endometrial pattern. The endometrial pattern can be a triple line pattern which favors implantation. It can be a hyperechoic pattern, a isoechoic, or a hypoechoic pattern. All this pattern will give rise to different rates of implantation or pregnancy. Along with the pattern, the blood flow to the endometrium is also important, and this is assessed by color Doppler examination of the endometrium. And this can be divided into four zones from the zone 1, zone 2, and zone 3, and zone 4. The zone 3 and 4, if the blood flow is present, it is supposed to be the best endometrium for implantation. And this is done by a very simple test of doing a color Doppler. Other modality of diagnosing thin endometrium is hysteroscopy. Hysteroscopy can tell you whether the endometrial vascularity is good or not, the endometrial thickness is good or not, are there any adhesions, is there any fibrosis within the cavity, are there any Mullerian abnormalities. So this is the best diagnostic modality. And one important thing about hysteroscopy is that you can follow a see and treat principle where you treat the thin endometrium in the same sitting. These are other pictures of hysteroscopy where you can diagnose Mullerian abnormalities such as septic uteri, and this can be treated in the same sitting either by using cold scissors or using bipolar current. If the endometrium is not improving, it's quite refractory to the treatment in the form of hysteroscopy or estrogen supplements, then in those cases we can diagnose some infectious cause of thin endometrium, which is called as chronic endometritis, where you will get a strawberry appearance of the endometrium, thickened stroma, and presence of micropolyps. All this will indicate that the endometrium is showing some infection, and in this case, you have to treat the infection first and then go on to the next form of treatment in the form of IUI or IVF. What are the modalities of treatment we'll have? So thin endometrium can be treated. It's not a condition that it may not be treated, but sometimes there is a refractory thin endometrium. So what are the usual modalities of treatment for thin endometrium? Thin endometrium can be diagnosed in an IUI cycle, natural cycle, or IVF cycle. I think whenever a patient has thin endometrium, the first and foremost thing is to see the cause. And I think hysteroscopy is how we can diagnose it and treat it in the same setting. So hysteroscopy, which is a very non-invasive procedure these days, where you don't require any anesthesia as well. By doing office hysteroscopy, you can treat the cause of the thin endometrium in the same setting. So there can be adhesions in the cavity, which can be treated by hysteroscopic adhesiolysis with cold scissors or by using cautery or bipolar current. You can do a lateral metroplasty on hysteroscopy or endometrial scratch, which has also shown to improve the endometrial thickness in the next cycle. After doing adhesiolysis and lateral metroplasty procedures, you can subject the patient to estrogen treatment. Estrogen therapy. Estrogen is one of the important female hormones which is very important for the endometrium to grow in the proliferative phase. And this estrogen priming is always necessary to prepare the endometrium. Endogenous estrogen helps in the natural cycles, but all those patients who have thin endometrium, we have to supplement them with exogenous estrogen, that is estrogen from outside. And this can be in the form of tablets. Estrogen tablets can be either estradiol hemihydrate, estradiol valerate, and we have estrogen gels, which can be applied to the skin, and the absorption takes place from the skin by a transdermal route. Other method of using estrogen is estrogen transdermal patch. Estrogen injections are also available in those patients who are refractory to these modalities of treatment. And this refractoriness can be tested by doing a blood investigation of measuring serum estradiol levels. Even after doing a hysteroscopy and using estrogen, if we are not successful, the next modality of treatment is use of vasodilators. Now, what is this vasodilators? So, vaso is a vessel, and dilators is to increase its size, dilate it. What are the vasodilators which we can use in routine practice to increase the endometrial thickness? So these are the nitric oxide releasers in the form of sildenafil citrate or L-arginine. This can be used to increase, or pentoxifylline. This can be used to increase the endometrial thickness. Other modalities of treatments like those drugs which thin the blood, so that it reaches the peripheral vasculature, such as low dose aspirin and low molecular weight heparin, should only be used in those patients who have thrombophilias or blood clotting disorders, which can also cause thin endometrium. So these are the vasodilators which will also increase the size of the endometrium. Now we come to the refractory endometrium. Using all the modalities which we discussed, that is hysteroscopy, use of estrogen and vasodilators, if they are not successful, then we call these cases as refractory endometrium. And in these cases, we can use higher modalities of treatment and newer injections which are available. So injection GCSF can be one of these, and this can be used either subcutaneously or direct injection into the uterine cavity. Other injections which can be used by local application are HCG injections, which can be used directly into the uterine cavity. The newest modality of treatment is PRP or platelet-rich plasma. If the functional endometrium is very, very poor, and on the hysteroscopy we are able to see a fibrosis of the cavity with a very residual endometrium, which is very, very less. In those patients, we can use a form of stem cells called as platelet-rich plasma, where we mobilize the platelets from the blood by using a GCSF injection, and then later on withdraw the blood from the patient and prepare this platelet-rich plasma and inject it into the uterine cavity, or inject it below the endometrium by use of hysteroscopy. So both these modalities have shown to give a better success rate in refractory thin endometrium cases. So we have modalities of treatment which can be used even if the problem is very, very severe. Other than platelet-rich plasma, we can directly use stem cells too, but the research of using direct stem cells, bone marrow-derived stem cells, is very, very less. So I'm not going to discuss it as a modality of treatment. Suppose the endometrium remains thin and doesn't improve, then we have to check for the vascularity. If the vascularity is good, we can go in for transfer. But suppose the endometrium size is optimum, and we have a failed IVF cycle in these patients of maybe thin endometrium or borderline endometrium, or where the cycle is failed due to endometrial cause. We have one modality of diagnosing the cause, that is the endometrial receptivity array. So endometrial receptivity array is a testing of genes present in the endometrium by doing the endometrial biopsy around 7th day after the LH surge in a natural cycle, and on the 5th day after starting progesterone. So endometrial biopsy is taken and the endometrium is assessed for the genes present on it. Around 238 genes are assessed, and then we come to know whether the endometrium is receptive, that is, whether it is able to take the embryo, or it is pre-receptive or post-receptive. Accordingly, we can plan the embryo transfer of a patient depending upon the ERA results. Newer and newer studies are coming up, and research is advancing, and we have some microbes in the uterine cavity which are also claimed to be important by some studies. And that's where we check for the endometrial microbiome assay, or the EMA test. This also assesses the genetic makeup of the endometrium and assesses the whether the healthy microbiome is present in the endometrium or not. And accordingly, the treatment can be given in the form of probiotics, antibiotics, and so on. Friends, science is advancing, and we have newer and newer modalities of treatment for each and every case. And thin endometrium is not an exception. So, thin endometrium per se, if the patient has had any previous DNC or infection such as tuberculosis, has to be treated. But for all those patients undergoing uh, fertility treatment in the form of IUI or IVF, this can be a distressing thing. The doctors telling you that the endometrium is not improving, but we have seen about the newer modalities of treatment of endometrium. So every advance in civilization has been denounced as unnatural while it was recent, and later on it was a proven fact that this did help. So friends, Thank you for your patient hearing. I hope I clear your doubts about thin endometrium. We'll take some questions. Is there any integrative endometriosis treatment? Basically, the topic for today is thin endometrium. The question is about endometriosis. I would answer this anyway, but the topic is not related to the topic. So, endometriosis is deposits of the endometrium in a place where they should not be. That is, ectopic deposits of endometrium, and this includes medical line of management, injectable line of management, uh, then surgical line of management, and proper fertility treatment per se. So this is the integrative endometriosis management. Can endometrial cancer be found early? Very less likely that endometrial cancer occurs in a reproductive age group. Usually, the age incidence, if you consider of endometrial cancer, it's more than 50 years, and it will be the opposite of thin endometrium. So again, this question not related to the topic, but that will be the opposite of thin endometrium. You will have a very thick endometrium. So a very thin endometrium is distressing, but a very thick endometrium can also be a problem sometimes. And patients having endometrial hyperplasia or endometrial cancer can have thick endometrium. However, whenever thick endometrium is present in a young female, we can do a paper biopsy of such a patient and send the endometrium for histopathology or biopsy examination, and then we can come to a conclusion whether the patient has endometrial cancer or not. However, it's very rare in a younger age group, common in older age groups. Why would one endometrium be thick? So, endometrium should be adequately thick. It should not be too thin or too thick. The adequate endometrial thickness for a successful pregnancy outcome is somewhere between 8 to 12 millimeters. But pregnancy has been also been shown in endometrium as thin as 6 millimeters and as high as 14 millimeters. So basically, the thickness should be around 7 to 12 millimeters. Do we have the next question? How endometrium help to conceive if low ET? How can be recoverable? So if endometrial thickness is low, that is there is a low ET, then we can have different modalities of treatment as we discussed about hysteroscopy, hormonal therapy in the form of estrogens. Estrogens can be used either in a tablet form, injectable form, vaginal use, or transdermal use. Then we can use vasodilators. We have discussed about that. Other newer modalities of treatment in the form of GCSF, HCG injections, pentoxifenolin, uh, platelet-rich plasma can all be an option for treatment of thin ET. And a good ET is very much necessary for a good optimal outcome of IVF. Does treating endometriosis increase fertility? So definitely yes. Endometriosis affects fertility in many ways. The quality of the eggs will decrease. It can cause some problems with the endometrial receptivity as well, and the ovarian reserve goes down as the age advances and the severity of endometriosis increases. So endometriosis is a different condition, and thin endometrium is different condition. So I would like to highlight it again and again. But since the question is asked, I'm answering that endometriosis is treatable and it should be treated. for all those patients who are taking fertility treatment. What is the best at-home self-isolation strategy to deal with pain for individuals with endometriosis during the COVID-19 pandemic? Again, this question is not related to the endometrium, but I would like to take it. Endomet self, I said there is no self treatment which should be taken at home for endometriosis. You always can take online consultation with us at Oasis Fertility or any of your gynecologists to see if you have already shown that gynecologist is better, or it's better to do a ultrasonography and to assess the size of endometriosis, and the size, if the size is more, if there is problem with endometriosis, we can give some medical line of management in this COVID times, so that we can avoid a surgery for the time being and delay the treatment of surgery, but medical line of management can help in such kind of patients. So I think last question is, what is the normal endometrial thickness? And the normal endometrial thickness is somewhere around 8 to 12 millimeters, and that's sufficient to give a good conception rate. Anything less than 7 millimeter or anything more than 14 millimeter is considered as abnormal. Sorry. So basically, thank you for your patient hearing. I would like to reiterate that we are functioning at Oasis Fertility in Wakad. Any of your queries related to fertility or thin endometrium, you can visit us at Oasis Fertility Dynasty Commercial Wakad. We have given our toll-free number where you can connect with us anytime for free online consultation. If you have liked the video, kindly do subscribe and share to those who need this information. Thank you for your patient hearing. Signing off, Dr. Nilesh Balkawade.